My name is Lieutenant Colonel Melinda Hamer, and I'll be moderating the next panel on technology and the consumer health experience. We're very privileged to have here today with us both Ms. Susannah Fox and Ms. Dana Lewis. First, I'd like to introduce Ms. Fox. She's currently principal of Internet Geologist LLC, a health and technology consultancy, and previously served as Chief Technology Officer of the U.S. Department of Health and Human Services during the Obama administration, where she led an open data and innovation lab. Previously, she served as an entrepreneur in residence at the Robert Wood Johnson Foundation, and for 14 years, she directed the health portfolio at the Pew Research Center's Internet Project, where she helped create and define a new market at the intersection of health, social media, and patient engagement. Her research has been featured in publications ranging from the Journal of the American Medical Association to the New York Times and Harvard Business Review. She also serves on multiple boards of nonprofit organizations and actively advises numerous biotechnology organizations and nonprofits. She'll be talking today about lead users of health technology and their impact on the field of wearables. And as a side note, we'll conduct the question and answer session at the end after both speakers have finished. So I'll turn it on over to you, Susannah. Thank you.
Thank you so much. It's great to be here. So I am an internet geologist. I look at patterns in the landscape of health and technology. I follow lead users. I look at people who are really pushing the edges of technology. That's often people living with rare disease. And what I've learned is that we need to listen to people on the front lines. We need to listen to patients. They know their own bodies, and we can learn from them, especially if we hand over the tools that they need to solve their own problems. I'm going to be using this concept of the lead user, so I wanted to give some background on it. It comes from work by Eric von Hippel, a professor at MIT. He first came up with this idea in 1986, and he identified lead users as people who identify and solve issues before anyone else in their field even recognizes a problem. Lead users generate new ideas for products, services, and processes and organizations that want to stay on the cutting edge of innovation look for ways to learn from them. Lead users modify existing tools and products to create something new that they need, whether that's sports equipment or an assistive device like a new prosthetic hand or a walker. Lead users create what they need with what they have on hand, and their innovations can transform industries. Another thing that I love to do is not only follow people who are pushing the edges of a field in healthcare, but in other industries. So for example, in banking, 50% of new mobile financial service innovations used worldwide were actually pioneered by lead users in developing countries, where there was both high need for on-the-go money exchanges and high access to communications technology. In healthcare, a study of 143 drug therapy innovations, 57% were new off-label applications of an existing drug. The lead users in this case were clinicians caring for patients. In emergency response, we just saw, unfortunately, another hurricane hitting New Orleans on the 16th anniversary of Hurricane Katrina. In emergency response, an example of a group of lead users is the Cajun Navy. These were locals who used their personal boats to rescue hurricane victims. They created what they needed with what they had on hand without waiting for permission from anyone. The COVID-19 pandemic created a new cohort of lead users, people living with long-term effects of the virus. And this is a timeline, just to remember how fast this happened. In March 2020, clinicians and public health authorities were telling patients that if they survived the worst effects of the virus, their recovery would take about 2 weeks. A group of people in an online health community, the Body Politic, started comparing notes about their symptoms and realized that they were experiencing illness that was not being recognized or tracked by anyone. So in April, Fiona Lowenstein, the founder of The Body Politic, published an op-ed in the New York Times that triggered an avalanche of attention, particularly among other long COVID patients who previously thought that they were alone in their struggle. A small group of Body Politic long COVID patients who happened to be trained in research techniques stepped forward to write and field an online survey. As lead users, they used what they had on hand, and that included Slack and Google Docs, and they collected, analyzed, and published the first report describing long COVID. There was no data, so they created it. Their success has been meteoric, and credit goes to both the patient-led research collaborative for their work and to public health leaders and scientists for recognizing its worth. The lead users were able to get the attention of the power structure with extraordinary speed. Now, you may be surprised to learn that I actually know of many examples of such innovative lead users in health and healthcare. Not many of them have garnered international attention and briefed the US Congress and the UK Parliament and set practice guidelines for their condition. But there is a pipeline of innovation that is operating under our noses. The internet gives us access not only to information, but also to each other. And it's that deceptively simple insight that powers what I call the peer health innovation pipeline. It's the subject of a book I'm writing for MIT Press, and I'm pleased to share a preview of my findings. The intake valve of the peer health innovation pipeline is patient communities. It's a magic moment when isolated patients find each other and say, I'm here, I see you. It's like when somebody motors up on a boat and you're stuck on a rooftop and they say, I'm here to help. It's like when Fiona Lowenstein published that op-ed in the New York Times and thousands of people realized that they were not alone. At this stage, they form groups and tell stories, they give and get advice, and for some, that connection is all they need. But then someone in the group has an idea about how to solve a problem that they all face. A team forms to create a prototype. They test and refine it. And if they're lucky, it works. That's fantastic. And again, for some people, that's enough. The small group innovation is where it stops. The innovation doesn't go any farther. But maybe there's an entrepreneur in the group who says, if we get funding and attention, we can make this better and we can help more people like us. Or a savvy leader at a company or a federal agency notices what the small group has created and they offer to help. Maybe they hold a prize competition to encourage people to share their lead user innovations. This is when the flywheel starts spinning as more and more people hear about the innovation peer-to-peer, and everyone who could benefit from it has access to it, whether it's a product, a treatment, or a process that is improved. But let's bring this back to wearables. How do wearables fit into this scenario? Well, just as the patient-led research collaborative used consumer strength tools to create industrial strength research, the American people are using consumer strength wearables to create industrial strength tracking data for themselves. I found some research conducted by Rock Health and Stanford University. It just came out in March 2020. And the full report is really worth your time if you're interested in this area. They found that 8 in 10 US adults track some aspect of their health, mostly using digital tools. Of those, 7 in 10 are willing to share their health tracking data with clinicians. About 1 in 4 are willing to share it with a government agency, and a smaller group is willing to share it with a tech company. 4 in 10 US adults own a wearable. They mostly use them for fitness, but about half say they are managing a diagnosed chronic condition using that wearable. They can be the Cajun Navy that we need, able to respond locally using their personal health tracking tools. My recommendation is to create pathways for lead users to share their innovations. We should build people's skills in personal science and self-tracking. We should open access to every data source possible. We should infuse the best, most promising peer health innovation teams with the resources they need to take their ideas to scale. The tech is here. People are ready. Let's go. And with that, I'm very happy to introduce my friend and one of my favorite examples of someone who's using consumer strength tools to create industrial strength innovation, Dana Lewis.
Great, and thank you so much, Susannah, for that phenomenal discussion. It's really incredible the impact of these lead users and patient advocates on the field, and it's exciting to think about the way forward. I'm sure there are probably already a lot of questions, but again, in the interest of time, we'll hold the questions until the end. So next, we'd like to introduce Ms. Dana Lewis. She is a consultant and creator of the Do-It-Yourself Pancreas System, or DIYPS, as well as a founder of the open source artificial pancreas system movement. She's a passionate advocate of patient-centered, patient-driven, and patient-designed research. Ms. Lewis has led numerous research projects that bring together diverse healthcare provider and patient perspectives, to include a Robert Wood Johnson Foundation funded grant project to scale patient-led innovation and scientific discovery. And she's also PI or co-PI on numerous other diabetes data science and artificial pancreas system related grant projects. Ms. Lewis's work has been featured or referenced in publications such as Nature, The Lancet, The Wall Street Journal, USA Today, and many others. Her other accomplishments include speaking at the White House's Frontiers Conference, the European Parliament, and she was also named Fast Company's 100 Most Creative People in Business. Please welcome Ms. Dana Lewis, who will now speak on the future of wearables. Over to you, Dana.
Thank you so much, Melinda. Thank you, Susannah, also for that kind introduction and the handoff to talking about saying, let's go, and we are ready. And you'll notice a mantra that I use in my presentation frequently is, we are not waiting. And that is a community slogan that came out of the diabetes community, of which I am a part. I've been living with type 1 diabetes for almost 19 years now. And I have the perspective that we as consumers, as patients, people in healthcare that you'll hear me talk about, we are more than ready for the future of wearables. It's been here, but there's sadly been a lot of barriers for patients and people to have access to wearables, to have access to the data, to realize the future that I think is already here. And I first want to contextualize a little bit of the perspective of living with diabetes. In my case, I'm living with type 1 diabetes, but there are millions of Americans and millions of people globally living with multiple types of diabetes. And because it's so common, there is a perception that it is well understood and easy to manage. But I am here to tell you that despite all of the tools and education and technology, diabetes is hard. Part of the reason it's hard is because the general recommendations and tools that people are given are not really good enough to do the job of a full functioning organ in your body. People with diabetes are told to, quote, eat right. But the question is, what is right? There's no one universal magic diet that works for everybody. Diet and your response to different foods is very individual and varies a lot. Similarly with exercise, we generally consider exercise to be good, but when you have diabetes, exercise can sometimes make your blood sugar go up, sometimes make it go down, and it doesn't do the same thing to the same exercise every single day. And similarly, your response to food every single day, even if you ate the same thing, would be totally different. And then also with taking your medicine, in people with type 1 diabetes and other types of diabetes that require insulin, you can take the same amount of insulin and get totally different responses in your body. And this is one of the things that makes diabetes so hard, is because you have all these variables going on, and yet the tools for people with diabetes are out of date and they're not good enough for helping us manage diabetes. We're often told to use single point in time measurements, such as the gold standard A1C test from a blood draw that you would get at a lab or your doctor's office or a hospital. And this is a reflection of the last 3 months of what your blood sugar has been doing. And that's used to make therapy and treatment decisions, insurance decisions. But this point in time measurement is about as useful as giving a pilot who flies every day a single data point about how all their past 3 months of flying has gone. It's antiquated and outdated and unuseful. And yet that is still the gold standard for people with diabetes. But we have tools and technologies such as continuous glucose monitors, where we've been able to go from single point in time, such as finger stick daily blood glucose measurements, to data points throughout the day. And that is one step forward. But the challenge with diabetes is we still have numerous variables, as I mentioned, that you can't measure and you can't track. Things such as sickness and stress and other hormone changes in your body, that can drive your blood sugar up and down. Exercise and food and insulin, as I mentioned, can drive your blood sugar up and down. And another challenge is that even if you inject insulin, it's not magic, it's not instantaneous. There's actually taking about an hour's worth of time in order to peak into your body. And then it lasts in your body with an exponential activity curve for upwards of 6, 7, or 8 hours. So it's very hard to keep track of. And again, I can speak personally to this as a person with type 1 diabetes. I have struggled for years to manage my blood sugar and adjust my insulin dosing. And what I'm sharing on screen now is a picture of my continuous glucose monitor graphs from back in 2013. And I share these graphs for 2 reasons. One is because that year, my doctor had asked me to share a week's worth of my data. And in order to share, well, first, this was me trying my hardest, but you'll notice that my blood sugar was going up and down and above and below those target lines constantly all week. And this was me being educated with an insulin pump and all the access and me trying hard, knowing that somebody was going to be looking at my data. And yet this was still the outcome. So this was a good week for me. And it was still less than 50% time in goal range. But the other reason I share this picture is because when asked to provide my data from my medical device, the only FDA approved software in 2013 for the physical medical device that I had was on a PC computer, and I happened to own a Mac. So I, as the patient, did not have the ability to access my own data off my device. So in order to share my data from my medical wearable with my doctor, I would have to take my phone out of my pocket, take a picture, email it to myself, download it, copy and paste it into Microsoft Excel, printed it out, and I handed this physical copy of paper to my doctor. And this is just one example of all of the hoops that patients and people using wearables have to jump through in order to access our own data that might be available to us in real time on a wearable. But in terms of slightly retrospective data access, it's nearly impossible. And one of the reasons that I really wanted access to my data is because I struggled with alarm fatigue from wearing this device year after year, and my brain got used to hearing the alarms. And so overnight, I wouldn't necessarily wake up if the alarm went off because my brain said, it's not important, even though it potentially was important and could have been a dangerous situation with a low blood sugar. And so I, as a good patient, quote unquote, would reach out to the manufacturers and say, I have a problem. Will you help? For example, could we make a different alarm sound that my brain hasn't been hearing for the last 4 or 5 years? Can we make the alarm volumes different so I could make them louder at night and quieter during the day? And I was told by manufacturers that they were working on it and it would be out in the next version. Years later, still isn't out, just so you know. So as a patient, I found myself between a rock and a hard place of I had a real problem. And if you Googled louder CGM alarm, there were tens of thousands of people looking for a solution as well. And the manufacturers were not meeting this problem. They were not providing a solution for tens of thousands, if not more, patients like me. And so I ended up having to build my own tools. I was lucky enough to stumble across a tweet on Twitter from a gentleman named John Kostick, where he had figured out how to get the data off the physical device that I had. His goal was remote monitoring of his son's blood sugar. I didn't necessarily need remote monitoring, but I thought if I could get my data off my device the same way he does, I could send it to the cloud and down to my phone and make my own louder alarm. And that's exactly what I did. I got the data to the cloud and down to my phone to make a louder alarm using an off-the-shelf app that allowed you to make different alarm sounds and louder alarm sounds, and it worked great. And once I had freed my data from my medical device and got it into the cloud, I realized I could do other things. I did eventually build a web page that you see here as a remote monitoring system, but I didn't just allow anybody to see it. I had certain trusted loved ones, and I built a tiered alarm system so that if for some reason I didn't respond to my alarms, it would then alarm them with all of the information that I had about my blood glucose, the insulin dosing data I had given it, as well as the information about what I had eaten. And so as a result, I was able to build not only a responsive reactive alarm system, but I was able to integrate my data into the cloud and build a proactive, predictive alarm system that essentially became an open loop decision-making system. And we didn't stop there. The challenge with diabetes is the person with diabetes is having to look at data from their fingerstick blood glucose testing or their continuous glucose monitor if they're lucky enough to have access to one. They're looking at their insulin pen injection data, thinking about that insulin timing activity or from the insulin pump. And you have to think about all of that math and all of those curves and make decisions over and over again, hundreds of times a day. It's estimated that people with diabetes make hundreds of decisions every day that impact their blood sugar. And that's a big burden. Again, we're trying to replicate the actions of a pancreas using little bits of wearables, but not good access to data, and it's really hard. And so ultimately what we were able to do once I had built that predictive algorithm, taking in data from the CGM and pulling in data manually from the pump, when I would input that data manually, we eventually found somebody who figured out how to communicate with the insulin pump. And that actually allowed us to fully close the loop, meaning that we could automate insulin delivery by reading data from the CGM automatically, then reading data from the pump, which was the new component, and having the computer run that algorithm with the data from the blood glucose monitor and the insulin pump and be able to decide over and over again, should it give more or less insulin? And this wasn't some huge supercomputer. It was a relatively simple algorithm using the same basic instructions I taught my then boyfriend, now husband, to use to help me manage my diabetes. It was relatively simple, and it was teaching him that made us realize that we could teach a computer to do the same thing. And so this is what OpenAPS looks like. You can see my insulin pump, the continuous glucose monitor, and that small mini computer we chose to host the algorithm that I had written. And on the right side, you see a visualization with the green line of what my blood sugar was doing. And that blue cityscape above it is a visualization of insulin delivery going up and down in response to my blood glucose levels. I was able to close the loop and build the system at the end of 2014. And I went from having those blood glucose graphs that I showed you before, up, down, high, low, frustrating high after frustrating low, all day, every day for years. Again, I've lived with diabetes now for 19 years. But after building the system, within the first day, I started seeing results that looked like this. Straight line after straight line after straight line. And I had built this magnificent louder alarm system that pretty much never went off anymore, because instead of having to wake me up and telling me to take action, the system would predict into the future that my blood sugar would be going to go high or low, and it would automatically adjust the insulin delivery. And note that the reason I did this, again, was first to make a louder alarm so that I would feel safe to sleep at night because I lived alone. But we were able to continue to solve small problems over time of first having data access and then being able to build an algorithm and then having access to other data from the insulin pump and being able to close the loop. And we didn't set out to close the loop. And we weren't trying to commercialize this technology. We chose to make it open source, which is why it's now known as OpenAPS, the open source artificial pancreas system that thousands of people worldwide are using. But we did that because the companies at the time had not yet brought such a solution to market. It took almost 3 more years for the first commercial solution to come to market. And just because one country in one place has one commercial solution does not mean that every person with diabetes in the world has a commercially approved, regulated approved solution available to them, and doesn't mean that it's affordable and accessible. And so people are still continuing to use OpenAPS, including myself, to this day for a number of reasons, including lack of access, lack of affordability, and many other issues. But I want to point something out. When we talk about patient-led innovation, user innovation, especially in healthcare, people say, well, you're so lucky. Diabetes is a data-driven disease. And so, of course, you did this. And if you hadn't, somebody else would have come along and done it. Well, perhaps, but you need to take into context the history of diabetes, which is that it has been a huge effort, decade after decade after decade, to allow people to have access to their data in real time. There has always been in diabetes and other conditions a concern that what if patients do something with their data? And if you have come from modern diabetes technology and you were diagnosed like I was in the 2000s or later, you almost take for granted the fact that you can finger stick blood glucose test at home. I was diagnosed in 2002 and I got a meter and I was sent home, and that's what you did. But when fingerstick blood glucose testing was first created in the 60s and 70s, there was actually a movement and pushback from clinicians who said patients shouldn't have access to this data. They shouldn't be able to fingerstick blood glucose test at home because they might change their insulin dosing in response to this information and they could hurt themselves. Well, yes, they could, but without blood glucose data information, they could also hurt themselves because they have to dose insulin either way to stay alive. And it took advocacy from the community of people with diabetes and clinicians with diabetes to advocate in the 70s and 80s for access to home fingerstick blood glucose testing. And thankfully that became a reality. But this theme of patients might do something with their data, they might hurt themselves, we must protect them. It has a culture of this harm from inaction that is sometimes more dangerous than the risk of action. And that's the culture that still exists today. In the early 2000s, there was concern as the continuous glucose monitors became available in diabetes that patients shouldn't see the data and that they should be blinded. And this should only be used by doctors retrospectively, but patients shouldn't have real-time access to this data. There were rightful concerns about accuracy of the devices, but instead of moving to teach patients how to deal with the noisy data or all the situations that might happen, there was a movement to restrict patients from going on CGM and preventing patients from going on CGM, in part because of the concerns about how they were doing with fingerstick blood glucose testing. And so how a patient did on prior technology was often used as a reason to prevent and block them from modern technology. And even today in the 2010s and 2020s, there is company pushes and regulatory pushes to prevent patients from seeing real-time data, to the tune that if you use a particular CGM, the regulatory bodies have enforced a requirement that the companies do not allow you to transport the data from their app into another place, such as Apple Health Kit or other apps, without a 2-hour delay, because patients might do something with the data in potential real time and must be protected from issues such as gap data or other issues. And it's really frustrating as a patient, despite somebody who is very knowledgeable and works in the healthcare space, because when you ask who made these decisions, there's a lot of finger pointing. Clinicians talk about the companies making this decision. Companies talk about the regulators. The regulators say, we didn't enforce that. We only make recommendations. And so there's just this finger pointing around and around and around, but there's no advocate for the patient in the room to say, look, the risk of inaction is worse than the potential risk of harm from taking action. And the risk of not seeing the data is greater than some of these hypothetical issues with regards to access from the data. And my frustration as a consumer is that healthcare typically designs data access and data flows for companies, then providers. And if you're lucky in a data-driven disease like diabetes, you as a patient might get access to some of your data, potentially in real time, but not retrospectively, or potentially retrospectively, but not real time. And we, as we're thinking about healthcare, as we're thinking about wearable technology, we absolutely need to be designing this technology for patients first, and thinking about all the important questions that were brought up in the previous presentation and the Q&A about how should clinicians be accessing this data, what real-time versus retrospective, what displays, what EHR integrations, all important questions. But we shouldn't have to wait for answers to the questions for providers in order to have this data available for patients. And so I want to flip that on their head. And there's a common phenomenon in healthcare in particular to assume that patients really don't know anything, right? Patients are the passive recipients of care. But I liken it to something like imposter syndrome, where with imposter syndrome, you maybe feel like everybody around you is smarter and knows more than you do. And in healthcare, there's typically the assumption that patients know very little and professionals know more. And I love the example that Susannah gave previously, talking about long COVID, where there was documented evidence that patients discovered this and documented this and proved this first. And that happens over and over again in healthcare, because the reality is that patients know so much. And yes, there's some overlap with regulators, researchers, healthcare providers, developers, et cetera, but there's so much untapped knowledge that we are just completely overlooking when we assume that patients are only able to be passive recipients of care and we must protect them, coming with that risk of inaction and the harm by inaction that is more acceptable than the smaller risk from action. So the three things that I have learned from being a lead user and innovating in the space and being a wearable user personally is recognizing that you don't know what you can do until you can try. I didn't realize I could build a closed loop automated insulin delivery system, but I could because I tried and I took small steps. And I didn't wait for the perfect system. I kept going, I took small steps, and I recognized that first, getting my data off my device and making a louder alarm was great. It wasn't the perfect system. I would have rather the company made a different alarm for me, but I would still be waiting 8 years later had I not taken that first step forward. So don't wait for the perfect solution that works for everybody. If you come up with a solution that works for 10, 20, 30% of people, those people deserve that step forward, even if it's not yet perfect for everybody. And also remember that small iterative changes are multiplicative. So it may seem like a small step forward to have interoperability of data, to allow patients real-time and/or retrospective access to their data. But somebody can take that data and do wonderful things, life-changing things for them and thousands, if not millions of other people. So if you're looking for a sign for wanting to take the next step forward, to make data available, to make a wearable available, to do the next thing, I encourage you to do it. I think the future is limitless. When we think about the future of wearables, I think we have so many opportunities, but we have to step away from the way we did things in the past, where we would place limits on people, on consumers, on patients from accessing their own data for the proposed purpose of protecting them. The risk of inaction is a lot of times in healthcare and with this wearable data greater than the risk of action. So thank you again for the opportunity to share some of this perspective. And I hope many of you will join us in saying that we are not waiting in making this future better. Thank you.
Thanks so much, Dana, for that phenomenal presentation. I think that was very inspiring to me, and I'm certain that your work has been incredibly inspiring to diabetics around the world. So at this point, we'd like to utilize the remaining time for a question and answer session. So we'll try to answer as many as possible. If you haven't entered a question yet, please feel free to utilize the Q&A box at the bottom of your Zoom screen. So just looking over the questions that we've gotten so far, we have one from a fellow diabetic saying that they're interested about the learning curve of adapting to new technologies and new systems, and particularly switching to a pump. So what aspects of the onboarding experience do you consider when you're getting diabetics onto your system for the first time?
That's been a big part of the conversation of the community. One of the opportunities of the open source technology is that anybody could use it. And it's one of the things that we thought a lot about when we chose to make it open source is how do we make it open source in a way that it is safe for people? And so in particular with Open APS and the original implementation that we did, you had to build it yourself. You had to be willing to basically put the Lego pieces together and say, I have an insulin pump, I have a CGM, I'm willing to do this. But we essentially added in different settings that were off by default. And so people would have to learn each step and be willing to turn those settings on to be able to go from essentially a reduced insulin only mode to adding insulin to the system to increasing that over time. And subsequent versions of the system that were then ported to an Android phone, there's a system called Android APS that uses the Open APS algorithm. We actually recommended a series of learning objectives that are built into the system. And there's certain periods of time associated with each learning objective or safety gate that you have to go through to progress into using the system fully. And so I think there's a learning curve for anything, like going from injections to an insulin pump. That's a very important learning curve. And same thing with a pump to a closed loop system. And so there's sometimes people who get newly diagnosed, they're so excited about the idea of automated insulin delivery, but the community very quickly advocates, you know, you might want to start with a pump first and get kind of comfortable with diabetes in general and the basics, because if your system breaks, your closed loop system breaks, you're going to fall back to that. And so having the fundamental basics as an underpinning for understanding how to use the automated insulin delivery system is really important. And that's also one of the things that we've advocated then to the commercial companies of thinking about that learning process, that learning curve, the onboarding, and making sure that people really understand the basics of what they're doing. I think it's really important, and it's a great question.
And I'll just add, Dana just illustrated a really key aspect of this, and that is that there is an existing community. And so as we see all the new technology coming out and the data capabilities, we also see this capability to connect to each other, that people are able to gather on social platforms. And again, people are using what is available. So they're using consumer strength social platforms like Facebook and Twitter and Instagram and Reddit. to find each other and to give each other support. And for example, to encourage somebody, don't jump to square 7, like start with square 1 and progress, and we'll help you. Like we'll help you answer questions. And I think that's a really key insight as in terms of a mind shift, that if you haven't seen this in your own life, if you haven't seen examples of peer-to-peer healthcare happening, whether you work for a federal agency or whether you work for a company, your customer is changing. For a medical device company that used to think of their customer as the clinician, think about it more as not only just that consumer, but the consumer's family, and all of the support networks that surround someone. Those are the people who are really the users of a product in this case.
Awesome. No, thanks for that perspective, Susannah. So I thought there was an interesting question about patient data ownership, and maybe I'll first direct this towards you, Susannah. The perspective was we need to own or co-own our health data. What, if any, regulations are there in play around patient data ownership?
So there's some really interesting stuff going on. I'm particularly interested in the work that continues in the Blue Button Initiative. It started at the Veterans Administration, expanded to CMS, so that, for example, Medicare beneficiaries can get access to their own Medicare data, to the claims data, and that is being expanded so that there's an API. They can open the spigot and send that stream of data to an app of their choice. And that is an example of the federal government leading the way. It's leading the industry and showing that there is a market for this in the consumer market and in the app developer market. That's the kind of thing that I'm really excited about. And the more that we can change things so that there is this sense of ownership of the data being cited with the consumer, the better. One thing that people talk about a lot in terms of privacy is HIPAA. Well, actually, the P in HIPAA stands for portability. And device companies like Fitbit, again, the consumer strength wearables, they're not actually covered by HIPAA. And so we need to look at what leadership do companies need to take? What leadership do regulators need to take in terms of making sure that consumers do own their own data, no matter what the device, no matter where the device sits? Because that, I think, is going to be really, really important to the future of how people are able to get access and solve their own problems like Dana did.
No, thank you for those important points. And I saw there's another question from Santosh, which was very interesting towards Dana. So Dana, do you have any perspectives from any users or patients from lower resource settings?
Absolutely. I indicated this in my presentation briefly, that one of the reasons open source systems are still very widely used is because of the barriers to access to things like insulin, let alone technology such as pumps and CGMs. There are many people in countries, even in Europe, where the government insurance plans will very happily cover insulin, but they don't necessarily fund or cover CGM, the continuous glucose monitor. And so that's cost prohibitive. And so the concept of then getting the government insurance to pay for new technology, such as the closed loop systems, they're not there yet. So many people are self-funding CGM and choosing to use the open source closed loop systems in order to get this automated insulin delivery technology as cheaply as possible and as affordable and as accessible as possible. But even in the US, you probably heard about the insulin pricing crisis and the challenges many people here face. There's kind of a constant battle for people with diabetes to get access to pump and CGM and insulin, let alone this newest technology. And I think there's always an uphill battle. Every year I have to reprove that I have diabetes and prove that I need a CGM because the insurance company looks at my data and says, well, your blood sugars are great, you don't need a CGM. And they try to deny my access to CGM supplies, which is part of the reason I'm getting really great outcomes in addition to my closed loop system. So I think that there is still a big need for these additional solutions. I think there's a need for competition in the market from the commercial companies to continue to bring their pricing down and make it affordable and accessible. And I also recognize that, again, not all of these commercial solutions that we happen to be lucky enough to have available in the US for some people and in Europe, they're not available in every country. They're not regulated and approved. So there's still work to be done in terms of the access and affordability on many fronts.
Thank you. And another question I thought was really interesting, and maybe for either or both of you, how can we help clinicians, physicians, nurses, et cetera, work with patients to use these technologies appropriately? You know, as a clinician myself, I know sometimes there's this divide between the provider and the patient. And so how can we get those clinician interactions to be more helpful and facilitative of utilizing technologies such as these?
Dana, do you want to start or you want me to take it first?
Sure, I'll go. I'll just say from the perspective of people with diabetes, we've seen great progress in the diabetes community with endocrinologists being willing to listen not only to patient perspectives, which is important, but to address some of the other questions. We have done research in this community by the community and by traditional researchers that have brought thousands of hours of data, millions of hours of data from this community and analyzed it and found that it is as safe, potentially as effective as other technologies, and is not posing additional harm. And so that additional research and different documentation the community has done in transparency, not only for the community of users, but also expecting clinicians and other interested individuals to look at that, has gone a long way to providing educational materials for clinicians to be able to meet patients where they are. And I think it's a great question because I do think that the healthcare community will struggle as more patients bring in new wearables, new technology of how do they interact with that? What do they do? And so we see it a lot, again, in diabetes, we seem to be kind of on the bleeding edge because we've had access to the medical grade wearables. But I think this question also applies to these other general wearables as well and many other chronic illnesses.
Yeah, and I'll add to that, I hear the hesitation a lot when I'm talking with clinicians around this idea of people kind of freelancing their health with wearable technology. And so the number one point that I make is people are already freelancing their health and now they just have better and more data. And the second thing is there is so much great research that a lot of clinicians just don't have time to keep up with. And so I think there's an opportunity for translation. How might we use professional societies to translate all of the research that is just sort of out there and published, but not being incorporated into practice because there are so many busy clinicians. When we actually have data to show the importance of wearables in terms of, there's some really interesting stuff around medication adherence. There's really interesting work around weight loss, around pain management. And so how might we all help each other, the clinicians and the patients and caregivers, to understand what the latest science is so that we can all really take advantage of it.
And one last quick comment I'll make on the topic of adherence, picking up on Susannah's comment in a previous presentation. Something to keep in mind is when I read a lot of research and I talk to a lot of researchers looking to study people with diabetes just on CGM, they'll comment about the adherence and nobody has perfect 100% adherence to wearing continuous glucose monitors. And I have to point out that the companies themselves mandate a 2-hour warm-up time for every sensor. So every 7 days, 10 days, whatever the sensor life is, there's a mandatory 2-hour gap. And so nobody will have 100% adherence to their protocol because the protocol is not designed based on real world use, recognizing that in order to go from one sensor to the other, there is an enforced gap time. So there's little things like that about the real world application of this technology that often get overlooked when you then look at technology, and it sometimes is used to shed a negative light on the consumer, on the person using the wearable. And I think that's also something that these details matter, and we should keep in mind about how they're used in the real world based on those requirements that are enforced on us as the user. I would love to use it without the 2-hour gap, but I can't. So that's just something that we have to keep in mind moving forward as well.
Awesome. Well, again, thank you so much to both of you, Susannah and Dana. That was a really incredibly informative presentation. And at this point, we'll have to wrap up this session. And the next session is going to be led by Mr. Niels Olsen, Chief Medical Officer of the Defense Innovation Unit. So I'll turn it over to you, Now, Mr. Olson.